Hey, y'all, it's me, your host, Coach Pilar Arthur Sneed. Thanks so much for joining me here for another episode of the Last 10th podcast. I have had such a great time with every single one of you throughout this entire season of the Last 10th podcast. So we have now concluded season 3 of the Last 10th, and I am here today to bring to you some bonus material. I thought it would be really great to merge science and running. I am here on the show today with Professor Alister Hart. Professor Hart is a world-renowned orthopedic doctor or surgeon?
Surgeon.
Surgeon. All right, orthopedic surgeon. He has pioneered the use of some 3D printing for hip surgery, robotic surgery, and the analysis of orthopedic implants. And the great thing about Dr. Hart is that he has also started an organization which is called Exercise for Science, in which they are looking at some research data to help us folks who are out here in the running world learn a little bit more about some of the science and facts of running. So, Professor, I am super excited that you are here today. Thank you so much for joining me.
Well, pleasure, and I'm really pleased to hear that you're interested in our work, which I hope will be of interest to any runner.
Absolutely, absolutely. So, as I understand it, you are a runner yourself. Tell me a little bit more about you and your own running practice.
Yeah, well, I'm 51, and about 9 years ago, a friend of mine showed me a picture of 47,000 people running the New York Marathon as they crossed the Verrazano Bridge. And I was so impressed by the picture that I thought, I've got to do that.
Yes.
I'd done a bit of running before, but I hadn't done a half marathon. In fact, I hadn't actually done a 10K race. I'd run up to 10K before. Mm. So anyway, I trained for it. It turned out that was the year that the New York Marathon was cancelled. So we ended up doing a marathon elsewhere in New Hampshire, and then came back the following year for the New York Marathon. But it was an amazing experience. I wanted to break 4 hours, which is a sort of first time marathoner, not really a runner. Was for me was actually quite a big deal, and I did push myself so much that when I got back to England, I could hardly walk, and for about 2 weeks I was walking around my hospital, which is an orthopedic hospital. It's called the Royal National Orthopedic Hospital. All we do is orthopedics. We have 2,000 employees, and the only thing we do is orthopedics. And all my colleagues asked me, well, why can't you walk? And I said, well, I've done a marathon. And they said, well, not surprised you can't walk. So anyway, that passed. And I think what was going on there was a quadriceps muscle soreness. Yes. But it felt like it was in my knees. And so when the opportunity came to study runners a few years later, I was pretty convinced that we were going to see some significant problems with the knees of runners. We did the largest ever study using MRI. We used the highest resolution MRI, and we MRI scanned people before they started their training, first-time marathon runners. They then did the 4-month training program involving approximately 500 miles of running, and then did the marathon, and then we scanned them again. And I really thought that we would see significant knee problems, and we didn't. We saw the opposite. So what do I mean by the opposite? When you start to get early wear and tear changes in the knee, you get something on the MRI scan which is called bone edema, and that is basically swelling or increased fluid within the bone. And it's the bone that supports the cartilage of our joints. So the health of the bone that supports the cartilage is pretty key to the health of the cartilage. So what we found, in fact, was that the 500 miles of running reduced the incidence of bone marrow edema in the runners. If you scan 100 people, you will find bone edema, particularly if they're midlife individuals, mid-age individuals. And particularly if you use a really high-resolution MRI scan. And that's what we did. We found that.
Yes.
In at least 20 people out of 100. But by the end of the running, 500 miles and the marathon, we found bone edema in less than 10. So it had actually improved.
Okay.
And cartilage issues, tendon issues, and so on, actually, which we did find before they started the program, did not worsen.
Okay.
So we found a lot of abnormalities, as you'd expect, on high-resolution scanning of a middle-aged person, but these did not prevent them from doing the training program for a marathon.
Absolutely.
A running marathon.
Absolutely.
And they didn't progress on scan, which is really astonishing.
Absolutely. Absolutely. So what are some of the contributing factors to the edema that you see in and around the structures of the knee?
Well, in terms of bone marrow edema, so the fluid within the bone underneath the cartilage, there are many different causes of that. The most common is pre-arthritic, so it's an early arthritic change, many years ahead of developing arthritis, which is damage to the overlying cartilage. So there are many factors, and clearly exercise is one of them, and it looks like doing exercise actually protects you and reverses bone marrow edema. Why might that be the case? Perhaps it's increased blood supply as a result of exercise and loading the bone and cartilage and stressing the muscles and tendons. We know that motion is lotion. We know that if you go into outer space and you do not have the force of gravity across your skeleton, then your skeleton will degenerate, even though we see astronauts undertaking exercise. It's just not enough. So these provide the examples to illustrate the fact that our skeletons and everything attached to them need forces to keep them healthy. And it looks like running gives you a lot of healthy forces in a high dose.
Absolutely. So it is the forces themselves that cause or help your bones and your joints, your cartilage, all of those different structures to kind of stay healthy.
Yeah, and I mean we've known that for many years. I mean, I gave you the example of the astronauts, but perhaps a more common example is as we get older, we all get osteoporosis, which is a reduction in bone quality. We all get osteoporosis, and we get osteoporosis faster if we do less exercise, if we do not stress the skeleton with normal life forces. Same is true of bones that break. We need forces placed across them to enable them to heal. But bone is a bit fussy, because if you put too much force and, for example, in a healing fracture, result in it moving too much, then it won't heal. If you put too little, it won't heal either. So a little bit like a Goldilocks and her porridge, wanting exactly the right temperature.
Sure.
Bone wants exactly the right amount of force placed across it. And what was not known before we did our studies was whether marathon running and the training for marathon running was just a bit too much force. And my personal experience of running marathons initially made me think that it probably is too much force. And our studies have certainly gave me more confidence to keep running longer and faster, keep doing races.
Yes.
And I think I'm going to be running for the rest of my life.
I hope so. I hope to be running for the rest of my life as well.
Yeah, it's a really good thing to do for you.
It's my hope. It's great not only for your body, but it's also great for your mind as well. It helps to keep your brain working. It's great. Yeah.
Yeah, I mean the medical evidence of all the different organ systems benefiting from running is becoming clearer and clearer. I think the effect on the skeleton and our joints, I think people don't quite believe that marathon running really can be that healthy. I think most people think that it's just too much of a dose.
I think so.
Yeah.
Most people they say, "Oh, you're going to hurt your knees if you keep running so much," or you hear often, "I can't do that."
And it's a very just a very logical thought that it is too much, but actually, it really does look like we were born to run.
Yes, I love that. And there is that book. There is a book that is called that, entitled that, "Born to Run." Born to Run.
There is by McDougall.
Yes.
And
yes,
it's mainly about barefoot running.
Yes.
Which is a bit unanswered, to be honest. The runners in our studies did wear trainers, or sneakers, or some sort of running shoe, anyway.
Absolutely, absolutely. So, exercise for science as an endeavor, are you primarily focused on marathoners as a group of people in your studies?
Well, we began actually as running for science, and then we were approached by some people who wanted other things investigated, in particular walking. And that made us think, well, to be a bit more inclusive, then maybe we should think of not just marathon running, and maybe not even just running, but the more we investigated runners, we thought this could actually benefit a much wider population. So in fact, the study we're doing at the moment with Public Health England, which is the NHS public health body, involves couch potatoes, involves people who don't run, really don't do almost nothing. And we MRI scan them. They download the NHS exercise app called Couch to 5K. And we've scanned more than 50 people at the moment. They're doing the exercise. We should get to 100 people soon.
Yes.
And then we will rescan them after the exercise, which only takes them to 5K. So well short of the 42-kilometer marathon.
Absolutely.
Yeah. But it's most people, to reach a larger number of people, I think we do need to not concentrate on marathon runners.
Okay. So how do people get involved in the studies that you are producing? I mean, obviously I'm here in the States, you're in the UK, but how do people get involved?
So it's through our website, exerciseforscience.org, and Public Health England marketing department produce a newsletter which is sent to several million people, and promote our study. We then filter the inquiries and make sure that we get the people that we need. It's not straightforward or inexpensive to undertake 3 Tesla, so high resolution MRI scanning of the lumbar spine, the abdomen, both hips and pelvis, which is what we're doing for this current study.
Yes.
I think in the States, if you had that MRI scan in your private sector, then I think you'd be looking at about $4,000.
That's a lot. Yes,
it is a lot, and we're planning on doing that for 100 people at least twice.
That's a lot. So it's like $800,000 ish.
Yeah, and then of course that's just the scanning, and then we then have to process the scans, and we've developed a sort of side angle of what we've done is an artificial intelligence method of actually measuring the scans, because when you've got such a large number of scans, and you want to record the data in a quantitative way. You want to measure, for example, the muscle volume and the muscle fat content. Then to look at each one will take about 2 days of processing.
Okay.
So we had to develop much quicker, smarter methods, and they now take about 20 minutes to process.
Right, as opposed to the manual way of you looking at each scan and basically saying, okay, this, that.
I mean, you can. I mean, our radiologists look at the scan, and for example, they exclude major abnormalities. For example, when you're scanning people, you can pick up occasional cancers or medical problems that you can't ignore. And that's the main ethical issue, actually, with running studies like this. You can't simply scan people without the medical backup and referral network to process incidental findings.
Right.
So that took a bit of work to sort out. But as doctors and myself, an orthopedic surgeon, I've got that referral network, and through the ethics committees, we answered all their questions regarding patient safety, or not patient safety, but individual person safety.
Absolutely.
And then of course so the radiologist does look at the scans for cancers and things like that. But what we really wanted to do was to quantify each muscle, each cartilage surface, each tendon, because we're recording the data in an awful lot of detail, and we need to score each structure, and then we could do statistical analysis on it. So for example, detailed. The muscle. Yeah, so the muscle analysis is easily the most detailed analysis of muscle ever done.
Got it. So one of the things that I wanted to go back to in terms of the studies of the knee, but also in terms of the studies of the hip, were they two separate groups of studies. But when you were evaluating the runners, so myself personally, when I did my first marathon, here we have the Hospital for Special Surgery, I believe is what it's called. They did a study which they were just focusing on whether or not strength work, a particular set of strength work, had any bearing on whether or not a runner would become injured, not become injured, whether the strength work had any effect on their marathon training whatsoever. So I participated in that study. through the Hospital of Special Surgery. So I was wondering if your particular group of studies is only focusing on the running aspect, or are there parts of the program that are also having runners do strength training or running specific strength training?
No, it's a great question. And Hospital for Special Surgery is a fantastic hospital. As they say, it's a special hospital.
Absolutely.
And I've been there several times and worked with people who work there. And the studies that they've done are really very informative. We've taken a different approach. We've emphasized our medical imaging skills and medical imaging analysis skills, and got computer scientists on board to help with the analysis of the scans. So we haven't investigated the strength training aspect. All the participants in our studies do undertake a standardized training program, and there have been quite a few studies on strength, but the gap in the market, as if you like, is with medical imaging studies. And as medical imaging has improved so much and has become so objective, it's become a really useful way to look at runners.
Got it. So let's talk about the hip studies that you've done. That's another area where runners tend to either be weak or strong. But how does running affect the structures of the hips in runners?
Well, again, I really thought that we were going to see quite a few abnormalities, and turns out that you don't. And it looks like, again, our hips are made to run. And even problems such as tendonitis, so common problems, gluteus medius tendonitis, rectus femoris tendonitis, sometimes tensor fasciae lata, overload syndrome, iliotibial friction band syndrome, which of course really is a hip and a knee problem.
Yes.
Actually, we did not see imaging evidence of these problems worsening as a result of marathon running, which, I mean, again, it really surprised me. And similar for the cartilage, and also for the bone.
Yes.
We did, in the hip study, we did add in some ultra marathon runners and some multiple marathon runners. And I remember some people in particular, and there's one lady who had run 240 marathons.
Wow.
She was in her mid-40s, and she was doing marathons more than once a month.
Yes.
But for many years, and her hips were absolutely pristine.
Wow. That is kind of mind-blowing, actually.
Yeah, I was so surprised.
Yeah.
And so, I mean, we've of course written up all of these results in medical journals.
Absolutely.
The knee study's been published in at least 3 medical journals, and the hip study has been published in 2, and there are several more papers due to come out from the imaging analysis side of it.
Yes.
But the story so far is basically both our hips and our knees look like they're robust enough to not just be able to run a marathon, but to benefit from marathon running.
Absolutely. I love that. Is good news for me.
Yeah, and hopefully, so my main job is replacing people's hips, and there is no way that I'm going to be able to replace everybody's hip. I'm going to be able to replace between 5 and 10,000 during my whole career. A drop in the ocean. So, but what can I do to help reduce the chance of arthritis developing into significant problems or needing hip replacement? And I think the answer is exercise, and that's what I'm going to be doing for a significant part of my remaining career.
Absolutely. So let's go back to your first marathon. You ran, well, you ran your first marathon. It was in New Hampshire, but then you got to New York City. So, I mean, what did you think?
I mean, it was amazing. A million supporters on the streets, bands cheering you felt like every few hundred yards.
That's right.
Such an interesting place to run through.
Absolutely.
Great camaraderie, waiting in the freezing cold, wearing an old t-shirt and a bin bag.
That's right.
To try and stave off the cold in those tents as well. And great finish in Central Park. I thought the bridges, when somebody said, well, the New York Marathon is hard because of the bridges, I didn't believe them. But then after you've run 20 miles, a little hill is like a mountain. And your bridges that cross the river are arched, and that arch is a mountain.
It is.
So they're absolutely right. In fact, I remember going to hospital for special surgery the week before and talked with a pathologist who's a very keen runner, who'd run the New York Marathon every year for 20 years. And when he found out that I was about to run the New York Marathon, he sat me down and we ended up not talking about any of the work we were supposed to talk about. I came out 3 hours later, having been drilled with all the facts on the marathon. It's a fascinating race.
Yes, it's a great race. It was my first in 2017, and when you say that the hills are molehills, this is so true. And they're all there in Central Park at the end. And you're like, why? Why is there a hill here?
That's right.
Who built this place like this?
Yeah, exactly.
And who thought to put a marathon finish at the end of this hill? Why did you do this?
Actually, what did help me was because there are so many people, you have to walk through the park and you're not allowed to stop because you have to keep moving, otherwise everything grinds to halt.
Yes.
And that walk goes on for at least half a mile, maybe even
forever.
A mile. And I think that really does help, because otherwise you just stiffen up, because what you want to do is just sit down and collapse on the floor. But turns out that gently walking probably is the really good thing to do after that.
Absolutely. I agree. You do want to just collapse after a marathon. I personally, every marathon that I have completed, I have cried. As soon as they hand me my medal, I just, it's just full on blubbering, crying, this emotional release that I have. I just cry like a baby.
That's right. So, I mean, that's a sign of how much you've pushed yourself and how much of a whole body and mind event it is.
It really is. It really is. It really is. So what have you been doing in this COVID-19 time for yourself?
I mean, I've had more time. We did continue operating, providing an emergency service, mainly for people with hip fractures. And we had to operate on them because otherwise they die. My hospital is an orthopedic hospital, and we took some COVID chest patients, but we took mainly injuries and hip fractures, some of which, of course, had COVID and some didn't. because the surrounding hospitals were closed for orthopedics. So we ended up doing more hip fractures than any other hospital in the UK during that period last year. And to help me keep sane, running really helped me.
Absolutely.
I ran, on average, it was about 50 kilometers a week. And I added in cycling. I found that cycling has helped me recover better from running, and is very complementary to running. So with the combination of increased time for running, I actually needed more help with recovery from running, and actually I found cycling was very good for that.
Excellent. I need to get a bike. That's something that I need to get. Don't have one, but I do plan to get a rower. A little bit more cost effective than getting a bike. And as I understand it, rowing is also a really great whole body movement.
They are. No, they are. They're both good. They're both forms of closed chain exercise where we're fixed to something. I think that cycling, for example, on an exercise bike, probably has the edge over rowing. I've done a lot of rowing. I rowed for my college, so I know a bit about rowing. But I think cycling has the edge because the pelvis is fixed in one position on the saddle, and the feet are fixed, of course, on the pedals. And so there's only one thing that they do, and it's consistent and repeatable, which is very good for the coordination and firing order of the muscles in your legs and hips. Rowing, slightly similar in the fact that the feet are fixed, but your pelvis is on a sliding seat, so it's not quite as static and simple as cycling. But I would encourage both for sure.
Absolutely.
Yeah, if you can add in, even if it's just 30 minutes twice a week of an exercise bike, I'm pretty sure that will help you. I've not read evidence to support that because I don't think a study exists on that. But having cared for a lot of patients that have undergone hip surgery, redo hip surgery, quite complicated surgery that would normally put your average person in a wheelchair, and we've had to recover them. The bike has really helped.
The bike has been the place to go.
Yeah.
So, Professor, thinking about all of the work that you have done in this research area with running and then now with walking, what are some of the key takeaways that you would like to give to runners and I guess athletes, in terms of the work that you're doing and for their own running practice?
I think apprehension that running might damage your hips and knees is understandable, but it really looks unfounded. And I think you can run with confidence that you're not going to do long-lasting damage. I think that we all experience aches and pains after running, and from what I've seen, those do not mean long-lasting problems. They do not mean arthritis, by and large. So I really believe we're born to run, and motion is lotion. And the dose of running, particularly if you follow a marathon training program, it looks like that takes you through a very staged and safe increase in mileage and intensity.
As long as you do it right.
Yeah, I mean
properly.
So when you say do it right, I think the only thing we've tested is people who've done followed the program.
Right.
Of course, you can do it right in many ways, different running form, different running shoes, different running
Absolutely.
surfaces, and it almost becomes so complicated, all the different variables.
Sure.
But we have now done 1,000 MRI scans of runners.
Wow.
So as we've increased the number of scans, we have hopefully reduced the effect of confounding variables, so variables that might otherwise explain the results.
Absolutely. Awesome. Awesome. And then my final question for you is, if you had advice for runners, athletes, people in general, it doesn't have to be runners. If you had advice, either maybe advice that you've been given or advice that you'd like to give, what would it be?
Oh, probably stretching. I
Oh,
think
yeah.
stretching really helps with recovery, and it makes you feel good. And that means that you can then get up and do your normal things the next day, whether it's your normal job, look after your children, and so on, or go on another run.
That's right. Just do another run. Which dogs.
That's right. And in fact, there's something called delayed onset muscle soreness, or DOMS, and it really does look like the pain you get the morning after. In other words, 48 hours after significant exercise such as running. The cure looks to be more exercise and more running.
I usually go for well, let me preface this by saying this. I have been running for today, once I go for my run, I've been running for 281 days straight.
Yes.
Every single day, a minimum of a mile a day, I have been running. The max distance that I've run in any given day in this year period of time that I've been running has been 35 miles, but the
Wow.
minimum has been one. And I have found that when my legs are super sore after a really, really long run, that little mile that I do really, really slow is super, super helpful. Yeah.
I think that's exactly right.
Yeah. Super helpful. When I first learned of the DOMS, when my coach way back when I first started, I was like, wait, what? DOMS? What is that? Is that like a pizza?
In fact, it's similar to how we rehabilitate patients after surgery. They're in pain and they're scared to walk, but the physios get them out of bed and make them walk, and it
Mm,
makes them feel better.
mm, indeed. Absolutely. And that's sort of similar to the idea of getting started in physical activity, right? Or you stop and then you have to get started again. So you stop and then you start feeling bad, or you take a break and you feel bad about yourself because you haven't been exercising. But the best way and the only way to feel good is to just go. Just go. Get it done and you'll feel better.
I agree.
Oh my goodness. Professor Hart, it has been an amazing conversation with you. I really, really appreciate your being here with me today.
Well, likewise, it's fun talking about running, and in particular, if it's part of your work, like it is for me,
Mm,
it's great to have that overlap, and it
absolutely.
certainly blurs the distinction between work and fun.
Absolutely. I agree. You get to talk about the thing that you love to do, and you get to do the work that you love to do too, which, I
Exactly.
mean, who can ask for anything better in their life? Awesome. Thank you so much for joining me.
Pleasure. Thank you for having me.
All right. I am going to stop